Have you ever thought of the human body as a crime scene?
That's a bit of a grim opening to start the day, isn't it?
No, stick with me here. I mean, think about it structurally. You have a detective, that's the doctor.
Okay.
They show up, and the scene is just, chaos. But the crime, the actual event that caused the mess, it happened days, maybe months, maybe even years ago.
Right.
And the doctor has to piece together this timeline from clues that seem totally unrelated.
You know, when you put it that way, yes.
Yeah.
It's actually a very accurate analogy for diagnostic medicine.
It is.
Oh, absolutely.
Yeah.
We often say the history is the diagnosis. The physical exam is just looking for fingerprints to confirm what the witness testimony of the patient's story has already told you.
Exactly. And today we're going on a deep dive into a medical mystery that proves exactly that. We have a case study of a 40-year-old woman. On paper, she is the picture of health. Married, totally healthy, no prior chronic diseases. She walks in with what sounds like a standard annoying ear problem. But by the time we unravel her timeline, we realize this is absolutely not just an ear problem.
It's a case that illustrates how a seemingly local issue, an ear infection, can essentially break down the barriers to the brain. That's a classic example of how fragile that separation between outside and inside really is.
It's scary stuff. We're talking about how a simple earache escalates into a life-threatening neurological crisis. So grab your detective hat, let's unpack this.
Let's do it.
Okay, so let's start where the patient starts, the beginning of the timeline. We're looking at exactly 1 year ago.
Right. And at this point, the patient's profile is remarkably unremarkable. She's 40 years old, no known comorbidities.
Which means no diabetes, no high blood pressure.
Nothing. No autoimmune issues, nothing that would make you expect a complicated runaway infection.
And her complaint is fairly specific. She has discharge coming from her left ear. Now, for the average person like me, this is annoying, sure, but is it an emergency?
At that stage. Probably not an emergency, no. The source material notes that this discharge started gradually. It wasn't caused by trauma. She didn't get hit in the head.
Or like water from swimming or something.
Exactly. Not that.
Okay.
It just started.
And here are the details that stood out to me, and I want you to explain why they matter. The discharge is described as grayish-white, foul-smelling, and mucoid. That word mucoid, it implies mucus, right? Like snot.
Correct. It means the discharge has a thickness to it. It tells us the mucous membranes of the middle ear are reacting to something chronic. But the real red flag there, the one that makes an otolaryngologist sit up straight, is foul smelling.
Why is that? I feel like all infections smell kind of bad.
A simple outer ear infection might smell a little musty, but when a clinical report says foul smelling, they're usually describing a distinct rotting odor. That smell is very specific.
What does it suggest?
It suggests anaerobic bacteria, and more importantly, it usually suggests bone involvement.
Bone involvement? You mean the bone is actually rotting?
Essentially, yes. It hints at necrotic tissue or bone erosion happening deep inside the ear structure. It points us toward a diagnosis of chronic suppurative otitis media, or CSUM.
Wow.
It's a sign that the infection isn't just sitting on the surface, it's eating into the architecture of the ear.
See, that's the detail I would have missed. And apparently for a while it seemed manageable. The sources say it was intermittent. She'd take oral antibiotics and it would clear up.
That is the false hope phase. It's very common. The antibiotics knock the bacterial load down just enough to stop the drainage, but they aren't treating the underlying structural problem.
And at this 1 year mark, she had no scary symptoms. No facial paralysis, nothing like that.
Correct. Just this stubborn, smelly ear.
So she lives with this for a year, just
Yeah.
dealing with it. But then we hit the turning point. This is where the plot thickens. We jump to 1.5 months ago.
This is the escalation phase. This is where the infection decides it's no longer content staying in the ear. It begins to invade.
The symptoms shift dramatically. First, the pain changes. It goes from just annoying to moderate to severe. And the description is really specific. It's a pricking sensation.
Pricking is a fascinating descriptor. It often suggests neuropathic involvement nerve pain, rather than just the dull throb of pressure. But notice where the pain is going.
It's radiating to the head and neck on the same side.
Right. And the trigger is key. It's aggravated by lying on that side, which makes sense, but also by eating.
Eating. That was the weirdest part for me. Why would chewing a sandwich make an earache worse?
It's all about real estate. The jaw joint, the TMJ, sits directly in front of the ear canal. There's very little space.
Okay.
So if there's significant inflammation in the ear, the movement of the jaw hinge is going to press right against that raw inflamed area.
So every time she takes a bite, she's grinding against the infection.
Exactly. It's excruciating.
That makes sense now. But then things get really alarming. Suddenly, she develops facial weakness on the left side.
That is a massive alarm bell. That is the moment where this stops being an ear case and becomes a neurological emergency.
Why so suddenly?
The facial nerve, cranial nerve 7, runs directly through the temporal bone, winding its way through the ear. If half your face stops moving, it means the infection has breached the bony canal that protects that nerve.
And it's not just her face, it cascades. She starts having trouble swallowing.
Both solids and liquids. The notes mentioned she was having coughing spells, specifically when drinking liquids.
What does that mean exactly?
That's a clinical sign called aspiration. It's incredibly dangerous. It means her throat isn't coordinating properly and she's literally inhaling water into her lungs.
And her speech becomes unintelligible. She can't articulate. And on top of all that, suddenly her vision blurs in her left eye.
So just pause for a second. We have a woman who came in with a runny ear. Now, 6 weeks later, she can't speak clearly, she can't swallow without choking, her face is paralyzed, and she's losing vision in one eye.
It sounds like a stroke or a brain tumor.
It looks exactly like that, doesn't it? But because we have that history of the ear discharge, we know where the crime started. This is the infection invading the skull base.
So let's connect these dots, because to me, it's wild that an ear infection causes double vision, the eye. How does that physically happen?
We have to look at the anatomy. The ear is housed in the temporal bone. Deep inside the skull, there's a part of this bone called the petrous apex.
The petrous apex. Sounds like a villain's lair.
In a way, it is, because when infection gets there, it's very hard to treat. It causes a condition called petrositis. And sitting right next to that tip are some very important cranial nerves. It's a very crowded neighborhood in there.
The wiring of the brain.
Precisely. You mentioned the vision issues. That's likely the 6th cranial nerve, the abducens nerve. Its only job is to control the muscle that pulls your eye outward.
So it's the muscle that lets me look to the side.
Correct.
Yeah.
Now that nerve runs right over the tip of the petrous bone. If that bone is inflamed, the nerve gets compressed, the muscle stops working, the eye drifts in, and boom, double vision.
Okay, that explains the eye. What about the pain behind the eye? The sources mentioned retroorbital pain.
That involves the 5th cranial nerve, the trigeminal nerve. This is the big nerve that provides sensation to your face. It has a massive hub sitting right on the roof of that petrous bone. When the infection underneath gets bad enough, it irritates that hub, causing that deep pain behind the eye.
It's amazing in a terrible way how this domino effect works. And the swallowing. The choking.
That tells us the infection has spread even further, likely downwards towards an opening where the 9th and 10th cranial nerves exit the skull.
The 9th and 10th. That includes the vagus nerve.
The big one, yes. It controls the muscles of the throat and the vocal cords. When those nerves are attacked, you lose the ability to coordinate swallowing and your voice goes.
It's terrifying to think the ear is sitting right next to all this critical wiring.
It is the gateway.
Right.
If the gatekeeper, the bone, fails, the invaders get access to the control room.
So we have a clear picture of a runaway infection, petricitis. But then there's a twist. A red flag that makes the doctor stop and say, wait a minute.
Yes. The event that happened 17 days before she came to the hospital.
The bleeding.
And we need to be clear here. Not just a little spotting. The sources describe it as profuse bleeding from the left ear.
Sudden onset. Not trauma-related. It just started pouring blood. They had to pack the ear in the ER to stop it.
This changes everything.
Why? I mean, infections make things bleed, don't they? If tissue is rotting, shouldn't it bleed?
Infections can cause some blood-stained discharge, sure, but profuse, spontaneous hemorrhage, where it's flowing out, that is extremely rare for a standard infection.
So what does that signal to a doctor?
It signals a neoplasm, a tumor, specifically a vascular tumor.
Something that's made of blood vessels.
Exactly. The sources mention a few specific suspects, like glomus jugulare tumors. These are rare tumors that are essentially sponges made of high-pressure blood vessels.
Sponges made of blood. That's a vivid image.
And accurate. If one of these grows into the ear canal and ruptures, you get this massive bleeding event. It's a hallmark sign.
They also mentioned ruling out hemangiomas.
Right, which are benign vascular birthmarks. But they ruled that out quickly because, you don't just wake up at 40 with a massive hemangioma you never noticed before.
So now the doctors are stuck. On one hand, the foul smell and long history sound like an infection. On the other, the massive bleeding screams, tumor!
And here's the headache for the medical team. It could be both. A chronic infection can hide a tumor, or a tumor can block the ear and cause a secondary infection.
But there was one other possibility they had to consider given the bone destruction.
Tuberculosis.
See, this threw me. I always think of TB as a lung thing. I didn't know you could get TB in your ear.
You can, and it's nasty. TB is known for causing osteitis, inflammation of the bone. It puts the cells that break down bone into overdrive, releasing enzymes that literally dissolve the bone structure.
That sounds horrific.
It is. A classic sign of TB in the ear is that the discharge contains tiny bony fragments. It's basically the dust of the destroyed ear bones.
So did this patient have TB?
The doctors deemed it unlikely.
Why? If she has bone erosion, it fits.
Because tuberculosis of the ear is almost always secondary to pulmonary tuberculosis. You usually have an active infection in your lungs first.
And this patient had no lung symptoms.
Exactly. Her chest x-ray was likely clear, no cough. So while TB was on the list, the lack of lung involvement made it a much lower probability.
Got it. So we're leaning back towards a malignancy, but before we get to the treatment, there's another scary thing they had to check for. Brain swelling.
Right. Intracranial pressure. When you have an infection or a mass pushing into the skull, the pressure inside can skyrocket. That kills you fast.
The notes mention checking for vomiting, but if your inner ear is messed up, doesn't that make you vomit anyway? How do you tell the difference?
That is a brilliant question. Labyrinthine vomiting from the inner ear is usually associated with vertigo, the room spinning. Vomiting from brain pressure is different.
How so?
It's often described as projectile. It can happen without any preceding nausea, and critically, it comes with other signs, a severe headache and altered consciousness.
And they also look for something called papilledema.
Papilledema, that's swelling of the optic nerve at the back of the eye. A doctor can see it with an ophthalmoscope. If that nerve is swollen, it's a direct gauge of intracranial pressure.
Fortunately, she didn't seem to have that specific complication yet, but she was still in bad shape.
Very bad shape. When she presented, she couldn't swallow safely.
So what's the management plan? What do they do for her right now?
Priority 1 is keeping her alive. Since she was aspirating, they inserted an NG tube.
That's a feeding tube through the nose.
Yes, nasogastric tube. It bypasses the paralyzed throat so she can get nutrition and hydration without the risk of pneumonia.
And I assume they started drugs.
Immediately. 5E fluids and broad-spectrum IV antibiotics. Even if there is a tumor, that foul smell proves there's a secondary bacterial infection. You have to treat that.
And speaking of seeing what you're dealing with, the expert in the source material really emphasized the order of operations here.
Yes, this is a crucial lesson. In modern medicine, it's so tempting to just say, put her in the MRI machine.
But the notes emphasize history first, then a thorough ear exam, then the imaging. Why does the order matter so much?
The scan shows you the anatomy, but the history tells you what you're looking at.
Give me an example of that.
Okay, take that bleeding event. If the radiologist looks at the MRI knowing she had a massive hemorrhage, they're going to look specifically for vascular markers that suggest a glomus tumor. Without that context, they might just report mass in middle ear.
So the history guides the technology. It tells the radiologist what to hunt for.
Precisely.
That brings us right back to the body as a crime scene idea. The clues were all there in the timeline.
They were. The year of minor discharge was the incubation. The shift to pain was the breach of the bone. The facial weakness was the invasion of the nerve canal. Each step was a breadcrumb leading to the skull base.
It's a sobering reminder of how interconnected we are. You have this ear problem, but suddenly you can't swallow or speak.
It highlights the vulnerability of the skull base. Nerves, blood vessels, hearing, balance, they're all packed into a space the size of a walnut. The collateral damage is massive.
So what's the takeaway for us? Aside from don't ignore a smelly ear infection, which I am definitely taking to heart.
Well, certainly don't ignore that. But the bigger takeaway is about the power of observation. The patient's description, the type of pain, the trigger, the nature of the discharge. Those details provided the roadmap before the CT scanner was even turned on.
And the distinction between annoyance and emergency.
Exactly. We tolerate annoyances. A year-long discharge is annoying. But the moment you have facial weakness, that is an immediate emergency.
And I think it's fascinating, in a terrifying way, how the body compensates until it can't. She was managing, until the nerve function just dropped off a cliff.
That's the resilience and the danger of the human body. The cranial nerves don't lie. When they stop working, something major is happening. The buffer is gone.
Well, this has certainly made me appreciate my ability to swallow a glass of water today.
It puts things in perspective, doesn't it?
It really does. It's a complex case, but the story is simple. A slow burn, a rapid escalation, and a race to figure it out.
And a reminder that listening to the patient is still the most advanced diagnostic tool we have.
Absolutely. So here's a final thought for you to mull over. We tend to think of our body parts as separate compartments. I have an earache, I have a sore throat.
But they're never just separate compartments.
Right. How often do we ignore a minor persistent symptom like that year-long drainage just because it isn't painful yet? We assume pain is the only indicator of damage. But in this case, the most dangerous damage, the bone erosion, was happening silently for months. It makes you wonder, what safeguards between the outside world and your brain are being tested right now without you even feeling it?
That is a provocative thought indeed.
Thanks for diving deep with us today. Until next time.
you.